Welcome everyone that is starting to come in. Come on in. We're glad to have you. Happy Lesbian Visibility Week. I want to take a moment to introduce our interpreter, Melissa Rogers. Thank you so much to Melissa for being here. And I'm Dana, and I am just going to give you a little bit of a welcome here. This is Beyond the Rainbow Health Equity for Lesbians and Queer Women panel. But before we begin, a few housekeeping notes. This event is being recorded for our archives. This probably won't be an issue, but please mute yourself in this event to avoid any interruptions. We also have our closed captions enabled, which you can turn on. We will have a brief Q&A portion at the end of the program, so pop your questions into the chat, and our amazing moderator will take a look at those. And then please feel free to share your feedback at the end of this event, either sending us a personal message to info@thecurvefoundation.org or on our socials, or just however you like. We'd love to get your feedback. And before we get started with the panel, I want to introduce you all to the Curve Foundation and to Lesbian Visibility Week. So a little bit about us is the Curve Foundation is the only national nonprofit that champions the culture and stories of LGBTQ plus women and trans non-binary people through community building, preserving history, and intergenerational programs like this one today. The organization was built on the legacy of Curve magazine, the groundbreaking lesbian publication founded in 1991. Now, Lesbian Visibility Week is an annual international movement that celebrates lesbians, queer women, and non-binary individuals. Founded in 2020 by Linda Riley of Diva Magazine and Diva Charitable Trust, LVW works to ensure that lesbians' lives, culture, and communities are visible across public, social, and cultural spaces. Lesbian Visibility Week centers community, connection, and diverse leadership, and Lesbian Visibility Week is powered by the Curve Foundation in North America. Please make sure you're muted and enjoy the panel. I'm going to turn things over to our incredible moderator, Jessica Halem.
Oh, Dana, you are fantastic. We are so thrilled to be here. I have not been in a room with this many amazing people in such a long time. So welcome, welcome. Thrilled for Lesbian Visibility Week. My name is Jessica Halem. I have been an out and proud queer woman, lesbian for over 30 years. So hello to all my menopausal friends in the audience. I'm a proud 53-year-old, which we'll probably talk a little bit more about that later. I have been deeply engaged in LGBTQ health for decades. And I can't say enough about how much I love doing this work. While some of the issues have unfortunately not changed, so much has. And I am joined today by three incredible panelists who I am lucky enough to get to call friends and colleagues. Each one of them has done so much on behalf of queer and trans health. We are so fortunate to be joined together. So a couple big ideas. I want you to drop into the chat. I want you to introduce yourselves to each other. Turn this into speed dating. Turn this into finding a good provider near you. We've got our friends from GLMA in the chat who can help you use the LGBTQ healthcare directory while you're here. Throw your questions in there. So let's keep this dialogue going, but let's kick off this incredible hour together by introducing our panelists. Deb, I will kick it over to you. Please tell folks who you are.
Deb Dunn, I've been practicing first 19 years was in the emergency room, but I'm a PA. Last 17 years exclusively LGBTQ, transgender medicine for the adult and the minor. I left a FQHC and now I have a private practice, a that where I'm seeing predominantly 16 and under trans minors who are coming from states where trans care has been banned. Also working as a director of gender affirming services for Planned Parenthood and have As of 2 weeks ago, every one of the Planned Parenthoods in Maryland have a gender clinic now that are in person and telemedicine. I was one of the founders for the Lesbian Health Center at Whitman Walker in the mid 80s. So I've been doing this work for quite a long time.
You sure have, Deb. We're so lucky to have you here.
Thanks.
Who's next?
Well, I mean, you called Deborah's name, so we're waiting for you to call.
Oh, I'm so sorry. Oh my gosh. Nothing like I love this crowd already. Dr. Lulu, you take up the ball.
I mean, I'm happy to do that. My name is Dr. Lizmay. I'm a Doctora Lulu. I'm coming to you from the land that was originally inhabited by the Muskogee Creek people, currently known as Atlanta, Georgia. But I represent my people, which is Nigerians, Igbo people. I'm proudly Igbo, always Igbo. I am also a mother of three blessed ones who are now all taller than me, all bigger than me, but I climb on a stool if I have to. My eldest is 28 and she is a beautiful trans princess. My middle is 25 and my baby is 22 going on 49. I am a pediatrician by training, retired 5 years ago after 30 years of being a physician, and now currently a life coach exclusively for the LGBTQ plus community. I'm a mom coach as well as I am an author, a speaker, and a adjunct professor at Morehouse School of Medicine and PCOM, where I help medical students, residents, and physicians with a brand new course that I created titled Intersectionality in Medicine, because why not? Happy to be here.
Thank you, Dr. Lulu. Dr. Beth.
Hi, I'm reading the chat while we're doing this, and I love that. And as somebody is on who is one of the most recent LHF grant recipients, so I'm also going to fill in for Deb here what I think she forgot to say, which is she is on the board of directors of GLMA, and Deb is the vice president of Lesbian Health Fund. So that's
how in the
very
world
important.
did I forget that part? I kept saying there's something I'm missing. But
It's
no,
okay,
that's
I
one of
got
the
you.
most proud moments is the Lesbian Health Fund, being vice president for that. So
I am Dr. Beth Oller, and I am a full spectrum family physician in rural Kansas. That is my primary patient population. I am also on the board of directors of GLMA and vice president of membership and development. I filled in as vice president of LHF when we had an opening for a while, which happy to do it, but glad that Deb is here now. I'm one of the few providers in the state of Kansas, certainly in rural Kansas, that does gender affirming care and has a large population of queer, trans, non-binary patients that find their way to me, which makes me so very happy. I also do work with reproductive care in our state. We are a state that still does have abortion access, but we have bans on care for transgender minors. So we are one of the ones that need people like Deb who are able to see our people that can't be seen elsewhere. But while that is a large part of my practice, I also still do see people from newborn to hospice patients and my 103-year-olds in the nursing home and love them all. I'm also the mom of 4 children with my co-parent and then a bonus baby with my life partner. So we are currently raising 5 kiddos between 6 and 13. So it's a lot, but
it would not be something called Lesbian Health Visibility Week if we did not showcase 3 incredible people who are doing so much on behalf of multiple communities. So I want to take a minute to sort of honor and recognize when we say the word lesbian, whether or not it is a word that you use or something you identify with or ever did, maybe in the past. One of the pieces of that conversation that I want to highlight is that it means allowing us to make space for those who carry water for others, those who are working on behalf of others, right? The advocacy that queer women bring to trans health, that we bring to HIV care, that we bring to abortion care, parenting. I just want to highlight how much I hear under this big umbrella of during Lesbian Visibility Week. And in the chat, I would be remiss if I did not point out, everyone, we are joined by probably 100 other amazing other healthcare providers on this chat. I see a lot of healthcare providers. I see a lot of researchers. I see a lot of folks all over the place doing amazing work. So let us be the conduit maybe for some your ideas and what you're working on out in the field as well. But let's start off with centering patients right now. I want to talk a little bit about what it means to be a patient in this world. I want us to reflect a little bit on the ways that the healthcare system is still not working for lesbians, queer women, bisexual women, pansexual women, non-binary folks, folks with a vagina, new or old, as I like to say. This big, big umbrella of people that we're all talking about today. How is the healthcare system still failing us? What does it look like to show up to a healthcare appointment? Maybe for those of us as patients, we could share a little bit. And for those of you on the panel, how is healthcare still not working? Right? What are some examples of how it is still not working for those of us as patients? Deb, would you like to kick us off? And what are some examples of the ways that healthcare is still not working?
Well, I'm going to answer this one personally.
Please.
My healthcare providers have never been, I've always had to educate,
Yeah.
and I've always been on top of what my preventive health should look like. And I've recently had to switch gynecologists who never asked me about my sexual partners, who, when I asked for an HIV test, asked me why I needed it. Um, and I've talked to other people from like health departments who said, well, how are we going to help out trans men? And I'm not sure what you mean by that. Well, they don't need pap smears. So if MDs and the oh, I almost said the commissioner of the state for the health department that told me that.
Yeah.
But
Yeah.
like if you don't realize that a cervix needs to be, have a cervical cancer
That's
screening.
right. That's right. A
Um,
cervix, anytime,
yeah,
any place, anywhere on anyone
mhm,
needs to be screened. Right.
yeah,
And I mean, Deb, why is that so? I mean, I could talk
mhm,
about, cervical health all day long. Why does it still matter for trans men, non-binary people, women?
mhm.
Why is this cervical cancer screening so vital?
Well, I hear a lot from my own patients that they believe that they don't need cervical cancer screenings. I've never had sex with a penis, so why should I have to have a pap smear?
Yes.
And you're at the highest risk actually. And what I teach medical professionals as well as my patients, if you got it, you got to check it. I personally lost three of my best friends and my brother between 2023 and 2024 because they didn't get their preventive care. Two died from breast cancer, one died from cervical cancer, and the other one died because they didn't get their colonoscopy.
Yeah. Yeah.
And so I just, all of my patients, I don't play. Like you don't opt out. If you have a prostate, at 50, if you've had a vaginoplasty, your prostate now is on top of your vagina, it's your P spot. It helps you have orgasms. If you've had top surgeries and you're a transmasculine person, you still have breast tissue. You did not have breast cancer, scoop all the tissue out. If you have a parent or a family, close family member that's had breast cancer, you still have to get your, mammograms and ultrasounds. And I know a lot of my patients have dysmorphia of getting colonoscopies. I get it. I'm this beautiful looking person, and you're going to look at the bottom, put me to sleep, and laugh. There's Cologuard. You poop in a box, ask your doctor for it. There's a box, you poop in it, you keep it in the refrigerator till you can take it to UPS.
Yeah.
Like, so
Yeah.
you may have to educate your providers, and I can't tell you how disturbing that is to have to do that. But
Yeah,
you
I
still have
agreed.
to do it.
We still have to do it.
Yep.
Dr. Beth and Dr. Lulu, let's stay on cervical health. Let's stay on these sensitive exams, colonoscopies. We've talked about some of the most. We've started off on the most sensitive areas of the body. That no matter how many years I've been working in healthcare, boy, is it still hard. How can we have these conversations? So what's some of the ways, maybe both of you could talk about your wonderful advocates. How can a patient advocate for themselves? What does that moment look like to have to educate your provider? What could I say that could actually work?
I recommend that my patients, if it's not me that they're coming to see, or if it is, make a list of what you want to cover before you go into that exam room. Right. If the doctor has a problem with you handing them a list, that is on them, not on you. You should have an expectation when you enter an exam room that the questions you want answered are going to be answered. I love it as a provider because it helps keep both of us on track and make sure that we have covered everything that the patient wants covered. And then I'm also going to make sure I go through all preventive things, but we have to normalize as providers as well, talking about sex. I cannot tell you how many ladies in their 60s I have come in that haven't had sex in years because it's painful, but nobody ever asked them. They were getting routine care, but nobody ever asked them, is sex painful? Does it hurt? You're going, I could have made the last 10 years so much better. Let's get you on some vaginal estrogen. If it's libido, let's talk about testosterone. Like, let's do these things. And letting people know, Deb, I hear the same thing. I have to convince often my younger lesbian patients or older ones that HPV doesn't care if it comes to you by a penis or a mouth or a toy or genital control. It doesn't care.
Grinding and scissoring is the number one.
Number one. And that's what we do. So I can, sometimes it takes convincing that you really do need this. And I think one of the things that's also been able to help me is my sister got colon cancer at an earlier age. So I've had colonoscopies and I can say to them, like, I get it. Look, I get it. And then we can kind of talk through that. But I think also letting people know when they are it's very disconcerting to have the idea that I'm going to go meet a provider for the first time. And if I need a PAP, I'm possibly going to be undressed and I don't know this person. Saying it's okay to say, I would really like to meet the provider clothed. And then if we decide that we're going to go on, like I will take my clothes off, but I would like to meet them in a more comfortable environment. I wish more of us normalize that. That is normal in my practice. That is what we do. But it is okay to ask that. And I wish we didn't have to be such advocates for ourselves in healthcare. But until we educate more providers as well, that's still very important. So don't be afraid to be an advocate. And if you reach pushback from that practice or that provider, it's not the place for you.
Dr. Lulu.
Yeah, well, I mean, how do I top that? I'm going to come from a different angle. I do not check vajayjays anymore. I don't check vaginas. I don't do clinical practice. So I'm going to come from a different angle. And I would like to actually have the chat open so I can see as many of the 99 people in the room who can just say me or say nothing. If you had formal training on LGBTQ plus care in medical school, residency, or as a fellow, go. Because I know you all can type. I don't ever talk at people, we talk together. So type in the chat. I want to see how many people got formal LGBTQ plus training. There you go. So one of the things I tell people there is good. No, right? That's what I want. I want to start from us. It always starts from us. We can sit here and easily say, do this, do that, and the other. It has to begin from us. So we were not trained formally. When I say formally, I don't mean an hour. I see someone that said an hour, 2 hours. That doesn't count. So if you're not, now close your eyes and imagine you went to see the dentist for a root canal. And the dentist said, well, actually, I wasn't trained on root canals. How does that sound? That's what's happening. So we have healthcare professionals who are seeing patients actively, and we have patients who are seeing patients and are not trained, and we have patients who are in the waiting room. There's a gap. Of course, there's a gap. So it makes sense that there's hesitation from the healthcare professionals and distrust from the patients. Let us name it. We're not trained. Yesterday, we were having our pre-meeting together and it came up. We don't have, listen, we're all learning on the job. And so I want us to hold space for your healthcare professional who may not have been trained. That's one. Then number two, it is time for you to say, trained or not, I want to be seen and I want to be seen right. And it's okay if you don't have the bandwidth to teach your physician. There's nothing wrong with that. But I want you to remember that this person you're dealing with was probably, maybe you're the first trans person they've seen. Maybe you're the first non-binary person who they know, because I always tell them that your patients are hiding in plain sight, because I've always been queer my whole life, right? Nobody ever asked me. So we're hiding in plain sight, meaning that you have queer employees, queer co-workers. It's not just your patients who are queer, but you have to know that you're not trained and be vulnerable. Allow yourself to learn, allow yourself to be vulnerable, and allow yourself to say, you know, I don't know this, but let me go figure it out. Maybe we can start from there. So I want to say that very, very loudly, so that when the patient is coming, like my kid who is trans, she doesn't have this high expectation that, oh, I'm going to go see the doctor. The doctor knows. I say, wait, honey, wait, hold up. Maybe the doctor doesn't know. So that we have patience, we have tolerance, and then we can coexist in the same space. Because guess what? If I'm a man who has sex with men and my doctor does not know, there's no way my doctor can take care of me fully. I have to be willing to tell my doctor that I'm a man who has sex with men. So it takes both of us. It's a tango, my friends. I want to just begin with that. Things that make you go, it's not that easy. We're not taught these things. So I just wanted to start with that. And then how many of us also normalize SOGI questions in the office? I told them yesterday at my class that for the first time in my adult life at the age of 56, I had a nurse at the VA ask me, so do you think you're gay? And when I asked people, I said, what do you think? How do you think I felt? Everybody says the same thing. Oh, you felt disrespected. You felt da-da-da-da. I said, no, I felt seen. Somebody asked me, no matter how she asked me. And that for me was an angle for me to now teach her how to say it. Ma'am, I'm going to ask you some personal questions, which we ask everybody so that I don't feel clocked, right? We ask everybody so we can give everybody the best care possible. If you lead with that, there's no one that's not going to tell you what you're asking them. So let's just remember that it takes two to tango. I'm going to just kind of start with that and then we'll go on.
Yeah, no, Dr. Lulu, you're absolutely right. And what I love about what you're saying is I'm hearing it through the lens of the moment we are living in which we can no longer expect our medical schools or nursing schools to integrate this anymore, right? Where we know that SOGI data that you mentioned, sexual orientation and gender identity, that might not be clinic-wide captured anymore. So what you're saying, what I hear you saying is, as a patient, I need to figure out how to advocate for myself, how to engage in this conversation, no matter what the politics are, no matter what's going on. The expectation is that I'm going to listen. I can be angry about this. I can feel frustrated. I might want to find a different doctor, but I need folks to go to the doctor. I need them to get these screenings. We cannot wait for the world to change. We still got to go and get what we need. So all three of you have talked through that kind of space, this liminal space of, I still need to get what I need. I might have to figure it out before I get there and not assume that the provider is going to know the right thing to do. And that still needs to be okay. And I still got to go and do it. And that's the lens that we're using right now. So let's get into it. You know, listen, I've heard make a list. I've heard vaginal health. I want to get back to sex because you don't have to tell me twice. If I get the chance to talk about sex, listen, it's 3:00 on a Wednesday. That's about my time. So, Debb, let's talk about you. We talked about this yesterday. We promised we would bring this up. Vagina tissue, urinary tissue, vulva tissue. This is sensitive stuff. It's related to our estrogen levels. Everyone with those tissues needs to hear, Debb, what do I need to know about that tissue?
Well, it's as you get older and your estrogen level drops, then you get atrophy and you can get tearing, makes you at risk of increased risk of infections, HIV, and painful sex. And it's really important for me to address the lesbian deathbed. Now,
Yeah.
for those of you who don't know LDB, it's lesbian couples of all genders and orientations. Now, I'm not, it's less that term lesbian is it's just a label. It doesn't tell you who you're having sex with. All right, back to the so those couples who haven't had sex in 15, 20, 25 years, you know, bring back your sex life. Like talk to your doctor. First thing I'll need you to do is look at your medication list. And if you're on beta blockers or SSRIs or antidepressant medicines, ask your doctors to switch you. Like I switched to Wellbutrin and it made a difference in my sex life. It I could never orgasm. It was so miserable. Like, and that is sexual dysfunction. Also, I'm gonna do a personal testimony because I'm in my upper 60s, and I think that you can learn from my testimony also. But I just saw my gynecologist last week, who is specializes in HRT, and I can't get estrogen because three aunts, five aunts, and my mom, they died from breast cancer and uterine cancer. So I've just got my fourth testosterone pellet. And I can't even tell you how it's changed my life. Like I am riding 10 miles a day on a bike. I have muscle. I mean, I'm like muscle person. And I was telling them yesterday, I can hump on anything. My sex drive is so high. Like it's crazy. Like my
It
mind
is
is
wild.
clear. I'm happy. I'm developing muscles. Like it just changed my whole world. And I just see so many people who feel like it's okay not to have a sex drive. And then if you have disabilities like arthritis and you're not comfortable using your joints, do different sexual positions. I always say lean over the sofa or like lean over the bed or, like the toys these days. They reach, they curve, they do everything. They do all the stuff. Um, and then just really make sure that you're getting really lubricated also. And don't, as you get older, your sexual orientation can change, and you will not lose your lesbian card if you have sex with male genitals. All right? If that turns you on, then you will not lose your lesbian card. And that's what you do. Have sex with guys. Just learn how to be protected. There's PrEP, there's long acting PrEP, there's PEP, there's DoxyPEP, there's all these different things. But definitely, you should be talking. Your doctor should be in charge and helping improve your
Right.
sex life.
And that can be hard to find the right kind of provider, but it's what you're reminding us is that there are biological reasons why our libido might change throughout our life.
Yeah.
And that we too often have been convinced that some of our physical ailments are all in our heads. And that what you're really reminding us is to take seriously the drugs, our diet, how to keep our
Yes,
bodies moving. All these things can affect our libidos.
that's
And
for sure.
and that we don't what I wanted to start off this conversation by saying, listen, if you have been harmed by the patriarchy, if you have been harmed by heteronormativity, you deserve to be involved in this conversation, and that is affecting our sexual health. And we deserve better. We all deserve better. Dr. Beth and Dr. Lula, I'm going to have you talk about, let's get into it. What other sort of sexual health conversations, maybe how to bring this up, how to advocate for yourself. Any ideas?
I think, kind of like I had said before, we as providers need to make it easier and normal to ask our patients about sex so that they know it is not taboo to talk to us about it. And I am the one that I want you to be talking to about it. But as a patient as well, do not shy away from bringing it up with your provider. Because guess what? If providers get asked about it more, they're going to have to get more comfortable talking about it. I often think that my Amazon on my work computer is probably pretty interesting if anybody looks at it, because I will frequently pull out my computer, go on Amazon, and show my patients the things I'm talking about. Show them the wedge pillows, show them the toys we're talking about, especially if we are talking about somebody who has had pain with penetrative intercourse of whatever kind. So they have not had it in a while, talking about how to start good lube, things like Replens that are out there now, using the vaginal estrogen, and then talking and showing them toys that are maybe similar to a dilator kind of set, right? Where we can work our way up and get the tissue used to being used again, and have these conversations that is okay. And that, look, hey, I know you might be 70 and you never thought you were going to buy a sex toy, but look, you can on Amazon right here, and it's going to come in a brown package and nobody's going to know. So I have those things pulled up on my Amazon because I want to show them that it's accessible, that normalize using these things, and also normalize toy use also in this straight couples. Because a lot of times as men age, and with a lot of different medications, erections are not what they used to be. And so kind of like the lesbian deathbed thing, Deb, it happens that way too, where they go, sex is over. And talking about how intimacy for any of us, no matter what parts we have, may look different than how we defined sex in our 20s or 30s. But that does not mean that you have to lose intimacy and that you have to lose sexual connection just because certain parts may not work like they used to.
That's right. That's right.
So I'm going to come from, I'm a pediatrician. I don't deal with elders, with all due respect to myself as a nearly 60-year-old teenager. I want to hold space for our youth. And I think one of the things that scare healthcare professionals a lot is discussing sex with youth. Let me tell you a secret. They're already having sex. Let me say that again for those at the back. They are having sex. And it's okay to tell the parents, come over here. Your kid is having sex. And one thing about that is normalizing the various ways kids define sex. Again, getting comfortable with having the conversation, but normalizing the various ways. Because if you, I told you all about my friend, maybe I didn't, Miss Tamara, who's 6'7", and just a regular good old-fashioned Canadian basketball player who is a lesbian. And she said every time she went to her doctor, every time for 10 years, they always asked to do a pregnancy test. And she was tired of them asking her about a pregnancy test. And she yelled out, I hate my doctor. You don't ever want your patient to be so frustrated that they say, I hate my doctor. And I'm using doctor here in parentheses for all of us. This is what Tamara said. So I'm quoting her. What I'm saying, you don't want your patient to just, they're going to say, no, I'm not having sex, because your mind, what you're thinking is sex is only one way, carnal. A lot of people, you want to ask them to define, what does sex mean to you? You can do that. You can use the what and the hows. You can ask what body parts that they use when they have intimate relations, but always empowering your patient by first asking them what, using what or how. You can never say no or yes when somebody asks you what or how. You have to have a sentence. So use those words that make you have an open-ended question, as they call it. And then whenever they say, you affirm them. One of the reasons why people shut down is when you have nonverbal body language. The person says, I'm non-binary, and right away you're like, well, guess what? They're not going to say anything else. Or they say, you know what? Yeah, last week I was gender such and such. This week I'm gender such and such. Oh, wait, what? Like, they don't need that. So I need you to practice everything you want to practice right here with your body language, because when you're in the room with the patient, and thank you so much, Lauren Schmitzlin, for affirming me. I can see you really nodding. I need that. As a speaker, I feed off of I'm an extrovert. I feed off of the audience energy. So I want to say, just remember to, number one, introduce talking about sex. Tell the parents you are going to talk about sex. Listen, when you prepare somebody for what's coming, they have a say in it. This is normal, what we do for, again, everybody, right? So that they get the best care. These are the words you want to use. And then if the parent wants to be in the room, that's on them. But you know that if the parent is in the room, the child may not be able to open up. So you may have to say to the parent, well, next week's visit, when you come in, I'm going to need 10 minutes with Sequisha, right? So that it's already ahead, so that when they come, they already know. And I want to say thank you to the person who said, please turn this convo into a podcast. Believe it or not, we already thought about that yesterday. So if you're coming to the GLMA this year, you're going to see more of us. And yes, we may very well end up with a podcast. I told them about this. All right, ladies, did I say this yesterday or did I not say this yesterday? Look at that.
Well, what's so important is that why this conversation is so beautiful is how much information the three of you have. I want to be able to bridging the provider patient conversation is so important because the three of you are experts. We have 10 more minutes, and here's what I want to get to some expert status. I know, because then we're going to get to some Q&A. People are going to put their Q&A in the questions if I haven't touched on it yet. But I want to get back to a little bit. We started to talk about screening. So the three of you know more than everyone else. So I'm going to quiz you on this. So let's talk about different ages. Maybe let's start with midlife. Deb, you brought up about colonoscopies. I want to hear, listen, folks, lesbians, bisexual women have higher rates of cancer. Now, why do we have higher rates of cancer? We don't have a lot of research. We don't have a lot of data. But what we do know is that when we do not go to the doctor, when we do not go for preventative care, when we don't receive the vaccines and the early detection screenings, because I do not go to the doctor, because I have been dismissed and trivialized, even assaulted and hurt inside of medical professional spaces, I ain't coming back. And if I don't go into medical spaces, I'm not getting those early detection screenings that can find the cancers early, treat it before it becomes an issue. So colonoscopies, skin cancer, lung cancer, breast cancer, these have wonderful screenings that if you get in early, we can find it and do something about it before it's advanced. But what happens with queer women is that we don't go because I'm pissed off and I'm tired of this bullshit and I think it doesn't affect me and I'm smoking more and I'm drinking more and I'm eating a little bit worse,
yes,
a little bit more sedentary because
yes.
this shit is fucked up and the world is difficult and I do a lot that maybe I shouldn't be doing and maybe I know better and maybe I don't. But I deserve a relationship with a healthcare provider that's going to see me and say, I know it is hard out there. But I want to help you get on a path because I want you living as long as possible. Old lesbians are the best kind of lesbians. Old trans people are the best kind of trans people. We all deserve to get old. So let's get into it. Colonoscopies. It looks like I should be getting it at a younger and younger age. If it's in your family, who can talk to me about? I love my colonoscopy. I'm not going to lie. I love it.
It is the
loved
best sleep.
It's a
It
good
is the best
start.
sleep.
Clean
It's the
it
best
out.
sleep ever.
But
you know,
not everyone likes it in the butt the way I do. Deb, tell us about colonoscopies.
well, because I don't want to forget these two important screenings for my gender patients that I see, my trans folks. Um, and I introduced this to the Planned Parenthoods in Maryland. So if you're in Maryland or you can travel to Maryland, I don't care if you're coming from California, we do self HPV swabs. So if you're a trans masculine or if you're a person who is not used to vaginal penetration, who have difficulty with speculums, then you can go in the bathroom with a pap swab. You swipe the vaginal walls, you put it in the same container as the cervical pap container. And then we can screen for HPV because we know 98% of cervical cancers come from HPV. And HPV is the number one STI for a female at birth too, that scissor, grind, oral sex. It's the number one. That's why it's important that you get your cervical cancer. The second screening is anal paps. So we see, especially with MSMs, but we're seeing a big rise in trans women. So, and that's caused by the HPV virus also. So it's the same thing. It's a swab, it's a rectal swab. You put it in a PAP container and you screen for anal cancer. And then the last screening that I think is so important is the 12 to 24-year-old now are the highest at risk group of HIV. So if you're not talking about rectal sex, which are 11, 12, and 13-year-olds, then it has to come from you because it's not coming from the parents, it's not coming from family practitioners, it's not coming from pediatricians. You gotta have the rectal sex talk. This is how you get this is how you get HIV. So those are three really important screenings that I know most people aren't doing, but are very important. But
Can
we
I
do have
add
life
something,
saving.
Deb?
Yeah.
I think also one of the reasons we see such high rates of HPV, especially in the queer community, some of us, like me, were old enough that the HPV vaccination was not,
Yep.
nor we didn't even have it, right?
No,
Like
there
I
so.
didn't get it until I was in my early 30s just because of age. There is, and I see somebody said in there, you can get HPV vaccine until age 44. There's also no too old, okay? A lot of the insurances will say age 44 and they'll cover it. I have given it to people in their 50s and beyond and have never had pushback on it. So the instinct, a lot of times I am doing a better job now as a provider asking about it, right? Because a lot of times before I wouldn't recommend it to my 30-year-old, 40-year-old, 50-year-old patients because it just wasn't in my radar until I got either somebody with early rectal cancer or somebody with an abnormal pap. So we also need to normalize. I do colposcopies in my clinic, which is for abnormal paps. It is rare. My nurse just knows. She'll laugh at me because she'll be like, "You're not going to let them walk out of here without their first HPV shot, are you?" And I was like, "Nope, we are not walking out without their first HPV shot." So that is also so important for helping to prevent esophageal cancers, right? We know it causes head and neck cancers, cervical cancers, and rectal cancers. And we are still caring for this gap of age group, which is all of us who are currently on this panel who were not adolescents when the HPV vaccine came out and was normalized.
Yes. I wanted to say something really quickly about the comment by Dallas Aita. I'm nothing if not an includer. This person, thank you so much for being so honest to say when we're talking about lesbian health and wellness and said because we were actively discouraged from going to the doctor. Right. I'm going to say this again for everybody at the back. That includes me. Nobody cares more about your health than you. I don't care what the person is to you. Nobody can actively discourage you from going to the doctor. That's why I started talking today by highlighting the fact that majority of us who are healthcare professionals do not have formal training on LGBTQ plus affairs. However, you are still in the waiting room and you still need to be seen, which is why Dr. Beth saying bring a list makes sense, which is why the list that Debbie is giving you makes sense. Listen, I don't care who the Secretary of Health is and what bullshit they're talking about vaccines. Vaccines help. I'm a pediatrician. I went to medical school in the 80s. I saw tetanus. I saw kwashiorkor. I saw marasmus. I saw diphtheria. I've seen polio. Y'all don't even know what I'm talking about. America is going to become a third world country in the next 3 or 4 years if we continue on this path. Do not wait. They say wise people, they say smart people learn from their mistakes, but smarter people learn from other people's mistakes. Do not sit there and assume that infectious disease is going to go away. I used to live in South Carolina. My practice was in South Carolina. Now I live in Georgia. They have over 600 cases of measles measles
So,
in America in 2026, while Mexico has just is about to start a DHS or NHS where everybody has insurance. You want to see the difference? So at the end of the day, what's going to save you is your own mindset and your own self-advocacy. I'm not going to speak for every physician, but I'll tell you that for those of us who are here, we're here because we care. We're here because we want to learn. You cannot get angry with all of us because some of us actually are affirming. So find the affirming physicians. If you can't find one, create one. Have a meeting with them. Be the focal patient. Help other people coming after you because knowledge is power. We cannot keep being angry and being upset. At the end of the day, your health is your wealth. And when you get sick, nothing else matters. Thank you for coming to my TED Talk. My name is Dr. Follow me. Follow me on social media.
I want to pick up on one of the pieces that keeps coming up, and it's the limitations of our identity language. You brought up about rectal, about HPV, right? And again, rectum, cervix, throat. HPV is everywhere. I mean,
yes.
there's a piece of it where I wonder how we can get better in our movements, in our FQHCs, in our advocacy, in our own personal patient advocacy, making sure that providers understand that I'm thinking about cancer, I'm thinking about keeping my body healthy, and that the checklist around identity doesn't do us much good. Right. And then I really want to center, like, how can I keep myself safe from HPV in all of my parts? Right. And when we make some of those assumptions using identity language, it really fails us. Identity language is very exciting and helpful for getting laid, for finding our people, for figuring out who we are. But when it comes to medicine, I really want to find a space where we can be more forward about our bodies, taking care of them, and these real cancer risks that you all have brought up. And I would be remiss. Now I want to pivot. I'm going to pivot because I think I saw my dear friend, Dr. Street, on the call. I want to talk about other preventative care. I want to talk about heart health. I want to talk about heart health because I am just so passionate about understanding numbers, right? What, as the feminist health practitioner, activist that I've been, do not talk to me about weight. Do not weigh me when I come into your office. Do not talk to me about BMI. But boy, you know what numbers I do want to talk about? I want to talk about blood pressure and I want to talk about cholesterol. So let's talk about, I know for a lot of people I heard, I can't get my wife to go to the doctor, right? I think I saw that come up. I guarantee you some of this weight bullshit is what's keeping a lot of folks from the doctor's office. Let's dig into that. Beth,
Yes.
Can I just say
And for my
something? Okay.
cat
first off,
saying
show us the
hello.
kitty. Show us. Okay. Yeah, Deb, Beth, please get in there.
Oh, I'm sorry. I didn't mean to interrupt that. I just want to say nobody's doing a study on the impact of implicit bias, discrimination, and stereotype, and is doing to the mental health and to the cardiovascular health. We know that cortisol is that stress hormone that happens when you're anxious, when you're scared, you're afraid people are going to discriminate, you're not making as much money as your other person, people are accusing, your family's rejected you. All of those we know now lead to abnormal insulin, elevated cholesterols, body fats. It increases your blood pressure, all of which cause cardiovascular disease. We got to start with that first. If we don't treat the things that are causing implicit bias and discrimination, I call it death by discrimination, then I don't care how you diet, how you exercise, a perfect BMI. Your life expectancy is going to be 15 years under that of a person. And we got to get comfortable going to mental health professionals. I mean, it does not mean you're not a strong person, but if you don't fix those stress hormones, the minority stress, that leads to these diseases, you'll never be able to treat your patient's blood pressure. You'll never be able to treat their depression, anxiety, substance use disorders. And substance use disorder and the LGBT community is outrageous right now for self-medication.
Right,
People are self-medicating.
that's right. That's
Yeah.
right.
And
So,
Deb, I'll
yeah,
circle
go
back
ahead.
around to kind of what you were saying about the other screenings and
Yeah.
about
Yeah.
cardiovascular health and
Yeah.
everything. And I think, we have talked about making lists, and I think we can make a list for different ages. I'm going to throw out there, I just turned 46, right? So if I go into a doctor's office and they don't do these things, I need to find a different doctor, right? What is the recommendation now for colorectal cancer screening? It is 45. It is 45 unless
45.
mine was earlier because I had a family history of early rectal cancer. And so then you do it earlier. I need to be getting a mammogram every year starting at age 40. You're going to see different things about every other year or where to start, but talk to any breast radiation oncologists and they will tell you every
Yes.
year. The every
Every
other
year.
year is some money saving bullshit.
Yeah.
And
Every
you
year.
need to be.
That was a little ACP moment there. I hear you. I know what you're we all know what you're talking
That's
about.
right.
Yeah.
I was interested in that. So every year,
you
right?
need
Okay.
to be having, and again, there is a reason why the Cancer Association, why hematologists, or why the Oncology Association, why especially breast surgeons will all say, absolutely not. You get them every year. So I should be getting a colonoscopy. I should be getting a mammogram. I should be making sure that I have a PAP with HPV testing every 5 years if it comes back normal. But the recommendations change based on what your PAP results are. But I also need to be having my blood pressure monitored. I don't care if I take a weight on a patient or not. If a patient says no, I say that is fine because it's not going to change how I treat you.
Right.
So I need that. And I want to do a screening on that patient for cholesterol and quite possibly, depending on family history, for diabetes. I want an A1C. I want to see when that's cruising up to pre-diabetes because for a lot of us, that is a huge thing that makes us turn around and go,
oh, absolutely. Does everybody here knowing your A1C? Know your A1C.
So your A1C is your average of what your blood sugars have been over the prior 3 months. So then when I hear but I ate cake last night, I'm like, honey, this is 3 months.
I know.
But when we start to see our cholesterol numbers creep up or our A1C numbers creep up, for most of us, that is a really good indicator of what we need to do. Then you make a lifestyle intervention, you check it again a few months later, you see the improvement. That is great validation. But for Lauren, who had said on there, how do I get my wife to go into the doctor? We have talked a couple of times about the LGBTQ plus healthcare directory. I would recommend going on there, looking for a provider in your area that you can know is affirming, that provides that care. And sometimes what we need is that push from somebody who loves us to say, babe, I love you. I want you around for a really long time. And this is very important to me because I want to keep you. So will you do this, or will you do this with me? Let's go together.
I was waiting for that.
I love my couples. Like, let's go together and let's meet this doctor and let's get up to date on all our things and let's go the same day to get our colonoscopies and have our other friend drive us. Like, let's get these things done. Or we go get our mammos together. We have a night at our hospital where it's just mammo night, so people don't have to take off of work. And we are a tiny rural healthcare facility, but we have snacks. And it's like, we call it smash and dash. And it's like, make it easy, make it kind of fun. And you can make spaces even in very rural communities. I have some of my trans and non-binary patients who have not seen a provider in years, who had certainly not had these things done. We are a critical access 20-some bed hospital. I have people that drive an hour. They will come and get their colonoscopies, their mammos, their PSAs, those things at our facility because they feel seen, they feel affirmed. You can make that, if you're a provider, you can be the change agent that makes that happen, even in a tiny rural critical access hospital in Western Kansas.
I want to say something because I'm looking at the time. We have 6 minutes. I want to say something. I want to echo what Debbie said. Listen, we're not going to pretend that we're living in a country that does not have the biggest, worst case of racism. So I am a Nigerian. I speak with a Nigerian accent. I'm a very proud Nigerian. No, I'm not wearing a hijab, but I might as well be, right? So I'm thinking about your multiply marginalized patients. The reason we have health inequity in America with 3Ks is because we do not yet have enough of us who are anti-racist. We do not have enough of us who are anti anything, even amongst the queer community, we have bi erasure. Amongst the queer community, we have racism. Amongst the queer community, I'm a mother of a trans daughter who, before she came out as trans, she was non-binary. People are like, well, what is non-binary? Well, make up your mind. I used to identify as bisexual. Now I'm proudly pansexual. I went out on a date with one lesbian. I'm not trying to call lesbians out. That's not the point. The woman is but the person. They're like, well, so which one are you? I said, well, what do you mean? Which one am I? Can I not be both? Is anybody monolithic? We have to also always we have to go first. Look in the mirror. Where are you lacking in your affirmingness? Where are you lacking in your inclusionness? There are enough of us who are like that. I got someone on my Facebook 2 days ago said to me, because I wear this bracelet on my hand, he said, rather than wearing a rope around your wrist, you should have a rope around your neck. 2 days ago, because I wrote a post about LGBT plus affirmation. Again, we do not have, maybe he's probably in the closet. We don't know. We do not have enough people who are anti all these things. My daughter is not coming to your clinic ever again. If one day she comes, she can't use the restroom. We have to be change agents. Listen, you can give me all the medicine in the world. If I don't like you, it's not going to work for me. So we have to be change agents. We have to be active allies, not just allies. We have to be visible allies. People have to see us from a distance and know that we're safe, so that when they come into your office, they never leave. It doesn't matter whether I say I'm non-binary or I'm queer. It doesn't matter. If I see you treating your coworker a certain way, you don't know if that person is queer. If your coworker sees you treating the next trans person a certain way, she's not going to tell her mother to bring her brother who is gay. We have to take responsibility for our own. We're the only human beings left. We're the only ones that are humans on earth. We have to take care of each other. Yeah. So racism is bad in America because we don't have enough anti-racists. Caitlyn Jenner, whatever his name is, her name is, was proud to announce that she's still a MAGA. We don't need people like that. If you have ability to open the door for other people who are marginalized, so that we will stop with the inequity. I'm just like, oh my God.
Well, on that note, let's I know we probably had lots of wonderful chat and questions and I'm sorry we didn't get to it all. I know the team from GLMA is on this call and they're dropping some helpful links in here. I know that the folks at Curve are going to think about all the ways that perhaps we can keep continuing this conversation. I just want to say, this is one of the missing links in queer and trans health. Are these out and open conversations with experts of different fields, of people who are willing to sort of ask the right questions and give great feedback. So I want to urge us all to maybe think about how we could keep this going and how we could continue to take care of each other. Again, it's rough out there, but maybe perhaps we could leave each other with what's one fun little positive piece you want to leave everybody with. Debb, we'll start with you. What's one little tidbit to leave our audience with?
I'm 69 years old. I'll be 70 in February, and I got married for the first time 3 months ago. We have a very active, she's going to kill me, sex life. But, I just got to say that we're going to try to make it a documentary because I need people to know in their later years that it's possible to find your soulmate, the love of your life. And so I'm gonna get beat up later, but
I
but
love
no,
it.
she'll be fine.
Yeah,
She's infectious disease, so
I love it. So we deserve love and care at all ages. I love
you
it.
get me beat up.
I love it, Deb. And we'll talk more about we'll talk about testosterone also. We'll keep talking about that, my favorite subject. Beth,
For me, for me, my
Dr.
going
Lou.
away word is I want y'all to remember to ask your patients about queer joy. Okay. I say this all the time. Just because I'm queer does not mean I'm unhappy or I'm suffering or
Right.
somehow something is defective. When I introduce myself as a Black queer immigrant physician, affirming mom of a trans kid, people look at me with like pity, like there's something wrong. Listen, if you don't know me, who do you know me now? I am the happiest person in spite and including all of those things, because I'm all of those things. So come out, be full, be who you are, but remember to ask your patients about affirming situations in their life, about queer joy. They're not all suffering. A lot of them
Yeah.
are happy. All right.
Yes.
Follow me on social media. I'm not kidding. I'm going to come for all of
Yeah,
y'all.
absolutely. Beth.
I think I would say, Jessica, that it's important to be seen. It's important to see yourself in your providers. It's important to walk in to a provider with a human rights campaign sticker on the back of their computer, like I have, and like Lulu has, with things that clearly
Yes.
show who you are, and letting them know also that they're, I always, just like I tell my patients, there's no right way to trans, right? There's no right way to queer. There is no right way to do right way, right? You don't have to fit into anybody's anything. And I want you to be able to talk to me about anything, but you don't have to explain yourself to me. And there is a huge difference in that.
Yeah.
So as a provider, be that provider. And as a patient, look for that provider who you can explain yourself to, but you don't have to justify yourself to.
Beautiful. Beautiful. I
Yay.
love you all so much. What queer joy on this call. This has been an hour of queer joy brought to you by the
Before
wonderful
we
folks
leave,
at Curve.
please, can we take a photo before we leave? For
Oh,
those who would
yes,
like to
please.
be
Somebody
photographed, that would be
take
so cool.
can't someone take a
And there are
photo?
2 pages or 3 pages
Is,
of all of us.
is
So
there
I
a
don't know. I
Gen
just
Zer here who could take a picture? Um, Everyone from Curve, thank you all so much. This Wellness Wednesday has made my week, made my month, made my year. Great. What should we do now? Should I
I
pretend?
know. Did we
Wait,
fix
I'm
it?
sorry.
Did we get
Felt
it
like
all
that was a
done?
great. What should we do? Dana, please walk us
Yes.
out. Where's my
Can you
walkout
hear
music?
me?
Yes.
probably asking the panelists where people can find and follow them is always a good way to
That,
end.
well, that's a
Um,
great way to end, Dr. Lulu. Where can everyone find you?
Put my emails in the chat.
I put my
I already put my stuff in the chat just in
You can
case you
also
didn't do that.
Facebook
But
or Insta
I
find me.
am, yeah, on
And
Instagram,
I'm on
Dr. Lulu's
LinkedIn
Pride
also.
Corner.com, and on LinkedIn at Dr. Lulu. And really, if you just Google Dr. Lulu and Oprah, you'll find me everywhere online. Please follow me, and tell people about my practice. I am holding space for LGBT plus people as the only affirming life coach in Vinings, Georgia, where I live, close to Atlanta, Georgia. So please tell the people to come see me. We have in person, we have virtual. We deal with relationships, coming out, your parent support, your physician, all of the things. Please come see us. We truly want to help you because we're here, we're in existence. So thank you so much for the time, for
Thank you,
listening.
Dr. Lulu. And if for some reason you can't find these incredible guests, message us at the Curve Foundation and we will connect you. Thank you, thank you, thank you for this incredibly important and very candid conversation about health equity for lesbians, queer women, and non-binary folks. This was so important. Thank you to Jessica, our incredible moderator, and our incredible guests. This has been a production of the Curve Foundation with incredible support from GLMA, GLMA. You definitely want to check them out. If you want to find an affirming physician, they have an incredible directory. So I've shared links with you in the chat also that you can leave your feedback for us for future programs. And as Lesbian Visibility is happening, I'm asking you, if you found this valuable, please consider supporting the Curve Foundation so that we can do this for the rest of time. We so appreciate you all being here. Thank you, thank you, thank you. And this was recorded so you could check it out again if you missed anything. Have a wonderful day and happy Lesbian Visibility Week.